So we're now on our last talk, and I'm sorry we're running a little bit late, but it's a really fascinating subject. This is From Waistline to Jawline, Managing Sagging in the GLP-1 Era. And I'm very excited to introduce Ms. Jonquille Chantrey, who is the founder of One Aesthetic Studio and specializes extensively in aesthetic medical procedures to enhance and rejuvenate the face and body. She has over 16 years of plastic and cosmetic surgery experience, and she's published many articles and peer reviews and is a key opinion leader at top international burns and plastic surgery conferences. So thank you so much, Jonquille, for your talk.
Thanks, Anne. I think we're at a really important moment, this symbolic moment in our practices where we have drug classes that are impacting systemic metabolic health but are showing up in our consultation rooms with such poor aesthetic results. So I think it's time that we really start to understand what's happening in aesthetic practice with these patients. I'd like to thank L'Oréal Dermatological Beauty for inviting me to speak on this topic and share some of my thoughts and experiences in my own practice, as well as an overview of what we're seeing in terms of the academic data. The very first time I saw a GLP-1 patient was in 2020, and it was between the lockdowns. So this was a patient who had, she was hypothyroid, she'd struggled with her weight for a long time, and she'd been a patient of mine for 10 years. And I reopened in the September, and she'd lost 5 stone. I could not believe my eyes. And I'm used to seeing a lot of patients who were post-bariatric surgery, but she'd been prescribed a GLP-1 agonist by an endocrinologist, and it really created quite a challenge for me in a very short period of time, because her expectations were so high in relationship to her actual phenotypical presentation. So just to share a little bit of work that I've published previously, we studied 14,500 consumers and 1,300 physicians in 18 countries, and we found consistently that skin health and skin quality was a key primary concern for patients who are aesthetic users and consumers. But another area was mid-facial volume loss. It consistently came up as a concern, as well as other aspects of rejuvenation. So how does that translate when we're now having patients who are on these pharmacological metabolic drugs? Again, from a psychological archetyping perspective, this was a paper that I published with 2 other plastic surgeons, and we studied 54,000 subjects in 17 countries. And we published in the JCD, and we came up with 4 different types of psychological archetypes. So one was correction, another was patients who want to be beautification patients. However, a lot of them were positive ages, and I'm sure they're the ones that you see in your practice. They say, I don't want to look younger, I just want to look really good for my age. Now, a lot of the GLP-1 patients that are presenting into practice are the positive aging psychological archetype. But the problem is that they're actually presenting as a transformation case because they are transforming their bodies, but they're still wanting to look very subtle and they're wanting to go under the radar. So that actually presents us with some significant challenges within our aesthetic practices. It's absolutely medicine at scale now. There's been a huge rise in prescriptions. Some data is showing a 325% increase in prescriptions outside of the NHS. And we're seeing huge body transformations, up to 25% loss of body fat, but of course that's also incorporating other muscle changes. And we have the celebrity glorification of these drugs, but the way that it's actually now funneled down into mainstream culture has been absolutely unbelievable. And I can actually see with so many of my patients the improved self-esteem. Just for clarification, I don't personally prescribe this in my practice, so the patients who I'm seeing are all coming to me for aesthetic support but prescriptions either online or from other prescribers. I think it raises many ethical dilemmas, and I think this is a huge topic that I can't cover today. But some of the key points are we medicalizing appearance? I think we've fought for so long in terms of body positivity, but where are we going in terms of that cultural shift again back to body norms? And are we fueling access inequality when it's now rising, the cost of these at £300 a month? Who can actually access this from a democratic perspective? Of course, we don't know any long-term data. Even though I've been seeing these patients since 2020 for 5 years, we still don't know in terms of the full adverse event reporting. And I think there's actual insufficient eating disorder reporting as well. So I think we have a huge ethical responsibility, and I think it's important to remember that our prescribing isn't a trend, and of course, it's a responsibility. In terms of the mechanisms of action, we know that it has significant impact in terms of the pancreas. It increases the glucose-dependent insulin, it's reducing glucagon, and it's also having an impact on the longevity of the beta cells within the pancreas. But it's also acting on the alpha cells as well. The fascinating impact is on the CNS. So throughout the mesolimbic system, not only is it impacting that hedonic eating and that emotional eating, but we also know that it's actually impacting the reward mechanisms as well because of the mesolimbic system. And then, of course, there's the physical aspects, the way it's delaying gastric emptying, etc. So we know that there's been huge proven medical benefits in terms of cardiovascular death, MI and stroke, and in terms of kidney disease progression. And I'm sure that this will then have an impact in terms of the physiological aging of these patients. But of course, we're seeing very different impacts in terms of in aesthetic practice. We're seeing those dermal architectural changes, and from a fat compartment's perspective, this is something that is one of the most common aspects. We're seeing the temporal loss that has been described in this literature. And this is in really high percentages of patients. And I don't know what you see in your practices, but that's something that tends to be a latter presentation type. Often we're seeing the separation of the lateral sousc and the buccal fat compartments. It really seems to be targeting those areas, which is creating this heavy jawline appearance and a descent of the jowl. We're seeing a lot of changes in terms of skin quality. There's patients that are describing the dehydration to the skin, they're describing drier skin, but there was a publication that was showing that actually there was improved inflammatory markers and there was reduced sebum production. But despite that, there were increased skin laxity scores in 45% of the subjects studied. This is obviously what we're seeing, and this sagging and this loss of skin tension. And as I was saying, we saw this a lot in terms of the post-bariatric surgery patients, but now what's happening is it's such a rapid, accelerated weight loss. Some of these patients are losing 2 kilograms per week. I mean, it's huge, huge weight loss that clearly the skin cannot keep up with that level of pace. Now, here is the hidden enemy underneath this. It's a long-standing enemy, is the glycation process. And of course, these patients, they may have had a high glycemic load for a long period of time. If they're obese, if they're diabetic, then their glycation process will have a heavy burden. So there's really quite a double hit with this, because then there's the collision with the biochemistry as well, and what's happening in terms of their glycated collagen. And then it's showing up in their phenotypes, and they're presenting to us and saying, we're feeling better, but we look like we're aging quicker. We know from consensus recommendations that early intervention is key and that it needs to be multimodality, as has been described today. And so before we had these consensus recommendations, it's always something that I've consulted with my patients. They'll often say to me, I'll wait to lose all of the weight and then I will come and see you for more in-depth procedures. But I've always said to them, you need to treat early, and these consensus recommendations certainly prove that. And when it comes to the surgical applications, it's definitely key to wait at least 6 months while these patients are stabilized. When it comes to collagen biology in clinical practice, as I said, a lot of it is also considering how we're going to manage the irreversible aspect of the glycation. So how do we prevent more of that? Well, we know that the GLP-1s are going to help to improve the glycemic load, but of course we need to speak to them more about their nutritional aspects. But we also need to protect the collagen that's already present and, of course, stimulate fresh matrix turnover. So I think there is an opportunity for a topical product to target multiple different layers of the dermis. This is a combination that's patented that is a novel flavoproxylane serum that's been recommended. And it has 30% proxylane with different types of wild fruits in terms of the flavonoids. So these are to stimulate the structural collagens and the GAGs. And then there are the boosters, which are present to improve the DHA anchoring and also act as an anti-inflammatory, which I think is key in these patients in terms of their glycation processes and their inflammatory load. So in order to test the efficacy of this serum, it was tested first from a histological perspective, both from a metabolic and a UV testing. And we can see that this was the improvement from the collagen 1, the tropoelastin, collagen 4, and laminin 5 throughout the layers of the dermis. So this was showing that could this serum actually start to improve, just from a topical alone, these patients. In clinical practice, we do use a lot of ultrasound. It has been validated. Of course, it's leaving the epidermis untouched, but going to around about the depths of 1.5 to 2 millimeters tends to create a better thermal injury for these sorts of patients. And so there was a hypothesis, if combining the ultrasound technology with this topical serum in GLP-1 patients, what could be the benefits? So this was a study performed by SkinCeuticals. It was a double-blind, randomized controlled trial, and it was split face and split neck. So here you can see that the novel serum was used on the left in this diagram, plus the cream, which had a lower percentage of proxylane, plus ultrasound. And then this was tested against placebo plus ultrasound. The study design, the patients had monotherapy for the first 4 weeks. Then at day 0, ultrasound was performed to both sides of the face and the neck. The subjects were then measured again at week 8 post-ultrasound. In terms of evaluations, it included safety, efficacy, and tolerance, clinical grading, and 2D photography. And it also included a self-assessment subject reported outcomes. In terms of the subjects, they had to have been on a GLP-1 agonist for at least 1 year and were on it for up to 3 years and throughout the duration of the study. I know that L'Oréal are committed to the representation of different Fitzpatrick types, and we can see the distribution through here. There was a predominantly females within this subject demographic. So looking at the results, firstly, let's assess the regimen plus ultrasound versus the baseline. So what we can see at week 4 versus week 8, there was a significant improvement at both time points, and this was against baseline. So this was measuring fine lines, wrinkles, firmness, and elasticity, but also overall appearance of skin condition. So when we were looking at the baseline aspects, these were the sorts of things. And this is definitely what we see in clinical practice. Patients do seem to be presenting in terms of the inflammaging aspects with the erythema and, as I was saying, increased problems with firmness and elasticity. When comparing the week 4 results, so just on monotherapy without ultrasound, it actually delivered 10 types of improvements in different key markers, whereas at the 8 weeks following the ultrasound, that rose to 16 key markers, including laxity and marionette lines. Then when comparing it to control, we can see that there was a significant improvement with the AGE regimen. So when using the AGE serum plus cream plus ultrasound, then we could see that there was a 16% increase and a 44% improvement. And this also translated to the marionette lines. And this can be actually very difficult to show with topicals alone. And also with ultrasound alone, often not just surgery is needed, but certainly 3D applications of different injectables to have any impact on the marionette fold. In terms of the dermatological review and assessment, there were 5 times the amount of subjects showed statistically significant improvement with the AGE regimen versus control. And that's what we can see in blue. And then finally, in terms of the subject-reported outcomes, this can be super useful when we're seeing those early results within these trials. So we can see that this is what they were reporting. They felt that the overall of their skin was feeling improved, but it felt smoother, firmer, and tighter. Here are some of the outcomes from this study. And it's important to note again that they were continuously on the GLP-1 agonist. Now, in terms of the gel formation and the gel fat, often what we see is that despite fat loss through the midface, what happens is that there is an increased jowling throughout the jawline in many of these patients. But you can see that actually there seemed to be an improvement in the position of the jawline with the combination of serum, cream, and ultrasound. And again, this was another subject that only had a relatively minor amount of weight loss during a 12-week period. But again, you can see an improvement with regards to the continuity throughout the mandibular line. And then here, in terms of laxity and the marionette fold, this was deemed significant from the dermatologists that were rating this. But this subject, again, actually gained weight throughout the study. So here you can see that perhaps the hypothesis shows that this may be a useful protocol for these patients and if treated early. With regards to how do we treat these patients holistically, within my practice, as I said, I've been treating these patients for 5 years, and within my own practice, I've had it for 15 years. So we have to go back to the nutritional optimization. Here we've seen the evidence-based topicals, but it also goes back to having the evidence-proven devices and the lifestyle medicine that is actually improving the cellular health of these patients. And when it comes to the nutritional aspect, I would say, there are many reports that patients are actually starting to become malnourished because it is switching off so much drive and interest in terms of appetite. And in terms of the fashions and the trends is what happens with some of these patients who perhaps are staying on it too long. What I always say to these patients is I review their protein intake. And there's a lot of debate as to how much protein should actually be ingested. But I roughly discuss 1.2 to 1.6 kilograms per day in different whole food form. And I always speak to them about the fermented foods and the improvement that can be achieved with that. But I think there's already been discussion around the microbiome today. I think there's going to be a lot of interest in terms of how the GLP-1s are going to be impacting the microbiome further. When it comes to patient-reported outcomes, here's a couple of the studies that I found very, very useful within my own research, because often in aesthetic practice specifically, the biological reality can really differ from what the patients are expecting. And so again, I think it can be very, very helpful when consulting aesthetic patients to regularly, within our own practices, audit and then use PROs as part of a wider aspect. I think, having said that, we still need to use those validated tools and really use that holistic aspect to consider every aspect of the consultation process so that it can really deliver the right solution for these patients. I just want to finish with some of my patients that were live injections. So as you know, these are usually under high pressure. This was at BTS Stockholm. And this was a patient who presented at age 50. She'd had a divorce, and she'd lost 5 stone in weight over a very rapid period of time. And the test for me at the Congress was dermal fillers cannot lift skin. So this was done with less than 6 mL of hyaluronic acid, and this was 1 hour later, immediately post-injection. So what we could see is that there was the clear differentiation around the orbital retaining ligament. There was descent and projection of that infraorbital fat. We can see the significant loss and descent throughout the nasolabial fat pad, and then the descent through the buccal fat through this position, which is then creating further more of this heaviness through the marionette fold and throughout the jawline. And normally this would be a surgical indication, but actually when it's placed in micro deposits in multiple different layers, both onto periosteum, throughout the fat, and also into the subcutaneous tissues with a cannula, then it can actually improve in a very rapid period of time. What you can see in the before in here, again, is a worsening when we tip the patient's face down. We can see that gravitational change. And here we can see how it will progress through the mandibular area, through the prejowl sulcus. And here we can see how, with just a relatively small amount of hyaluronic acid strategically placed, we can see the improvement. Now, the other thing that we tend to see with these patients is here we can see the upper eyelid hooding. But then, whilst we manage the mid-face and the lower third strategically, it actually starts to improve their frontalis lines because the rest of the mid-third and the lower third of the face is being weighed down. So it appears to create an improvement indirectly on the upper third of the face as well. Here's another patient of mine who was a live injection webinar, she was 35 at the time. And I was starting to see these glycation processes, this increase in elastosis to her skin, and she was planning to lose further weight. So in terms of an examination with her, what we could see was an increase in the submandibular and the submental fat descent. We could see an increase in the elastosis to the skin and throughout the infraorbital hollowing. But when looking at her on the side lateral profile, we can see that she lacks a Pagonian fat pad, and also there is a retrusion to her chin. And when you see her on smiling, we can see that mandibular inferior positioning with regards to her maxilla. So here's her immediate injections, and this was 1 hour after treatment by just using less than 5 milliliters of hyaluronic acid throughout the face. So here we can see that I anchor pointed throughout the lateral zygoma and lifted up the mid-face throughout these positions, but retained the contour. And then critically, in terms of the elastosis and the excess skin and fat, we can see that there was improvement immediately throughout the jawline in that position. Then when looking at the retrusion and the lack of Pagonian projection throughout the chin and anterior mandible, we can see by actually improving in relationship to her natural mathematical measurements, we can see that there was an improvement throughout the anterior Pagonian and then a shortening throughout the submental line. Finally, this was a mother and daughter case. This was at AMWC Monaco, and this was the launch of a major hyaluronic acid filler. And before this, actually, we never saw any jawlines and chins injected on a stage. So this patient of mine, she was in her early 30s, a millennial, and she was getting married 3 weeks later. And she had dropped the weight to get into the dress. And she said to me, I can suddenly see a complete change in my jawline, and I'm seeing this real heaviness throughout my neck. What can you do? And this was her mother. Again, she'd lost some weight. And again, all of the hallmarks that I've said about the different facial fat pads and the descent throughout all of the subcutaneous tissues were presenting themselves. So in terms of the mother, what I did, I had a little bit extra time. So I used cryolipolysis to the submental and bilateral submandibular areas 3 months prior to the wedding. And then I injected her with just 3 milliliters of hyaluronic acid to create more of a confluence throughout the midface and leaving what we can see as these malar mounds, the malar edema and the festoons, and then just starting to improve again throughout the mandible. So these were the immediate results after 3 months, combining the two. And we can really see that there is a difference. So actually combining again those modalities in fat loss patients can significantly improve without problems with excess skin. This is the daughter. I had 15 minutes to do it on the podium, which was pretty tough, to be honest with you. And this was less than 5 mils of product. So again, we can see a very gentle anchoring onto the periosteum throughout the lateral zygoma and through the anterior aspect of the maxilla to directly lift up the jowl positioning. And then the posterior aspect at the gonial angle, we can see that 1 hour later, immediately off the podium, there was an improvement in the submental angle. And importantly, this happens throughout all different aspects of expression. And as we can see here, actually, again, we could see that there was a slight degree of protrusion throughout the chin and the anterior mandible and the pagonian, which was then improved and stabilized when injected anteriorly. You can also see that on this picture through here. This was her then 3 weeks later at the wedding. And again, we can see the submental improvement, which was what her presenting complaint was. So this goes back to finally, what are we going to do with these weight loss patients? It's got to go back to a quality of life focused practice. As I said, I think there's many ethical dilemmas that are beyond the scope of this talk. So I think we need to really self-reflect when we're seeing these patients individually and with regards to the last talk that we had when we're educating en masse. There are huge emotional aspects to this, and I think we need to be really speaking to the nutritional and the eating habits of these patients. Again, within our practices, discussing our staff competencies and understanding the language that's used. And then finally, perhaps measuring success differently and going beyond all of the things that we know in terms of the histology proof and the before and after pictures, but actually how the patients are feeling about themselves. And reminding ourselves that there isn't any one procedure that actually, or drug, that substitutes for more healthy living. Thank you very much.
Thank you so much, Jonquille. That was fantastic. And I think any of us that work in aesthetics know how difficult volume loss is to treat, and this whole GLP-1 is a whole new issue around that. Just a question I had for you around HIFU. Have you ever had problems with more fat loss or loss of subcutaneous tissue with HIFU?
Yeah, I haven't seen it with my own patients, but I have inherited a lot of patients, particularly with one specific machine that had a huge amount of press associated with it. And I saw it quite early on, around about a 3-month mark, and then there were other patients that were presenting around about 2 years later. Again, all the way through the buccal aspect, but specifically through the pre-parotid. So around that parotid area, a lot of patients were presenting through them.
Fantastic, thank you. I think we've just got a couple of questions. James came through about social media as well. So somebody asked, is there a good resource for clinical images that can be used in social media content that doesn't breach copyright? Do you want to come up here?
I don't think it's working.
No, I don't think it's working. Do you want to come up?
I'll come down quickly. It's okay. Yeah, that's a great question around image use. So there are no guidelines currently around which images you can or can't use. You have to be careful based on the platform you use. So YouTube in particular, if you go to their general community guidelines, have got pretty comprehensive guidelines around third-party images and what you need to declare. You do need to be really careful though. I've only had one copyright strike, and actually it was on a dermatological video on keloid scars. I used what I thought was an open access image. It had the CC BY 4.0 license, I put it up, it was doing really well, I think it had 60,000 views, then I got the copyright strike, and it had been submitted by the owner of it. Whilst it was an open access image, I had to apparently email him beforehand to make sure it was okay to use on a YouTube video. So I would say just be careful about that, but there are no existing guidelines at the moment and probably a gap that needs to be filled for dermatology.
And another question for you is, how do you deal with difficult comments from people as you can't control their comments?
That's a great question as well. So there's two different strategies. One is you leave the comments on. That's great if you want to drive engagement on the video. The more comments, the more likely the video is going to be pushed by the algorithm. The challenge there is you have to actively monitor them, which can become challenging as the channel scales. There are tools available to do this, or you just need to hire someone to manage the channel if it gets that large. The second is obviously to switch them off, which is what most, say, pharmaceutical companies do, but then that risks the video not getting the community engagement. I think it also varies depending on the platform you use. Generally, I would say 95% of the comments I get on YouTube are great and very supportive. Other platforms such as TikTok, I think it can be very variable, and there can be misinformation propagated within those comments. There's guidance within the Academy of Medical Royal College guidelines about how you should handle that, but it's still version 1.0. There needs to be probably version 5.0 by now.
Fantastic, thank you so much. So I think that's us done, and we've really managed to cover all sorts of topics today. So we've done some aesthetics at the end, some Instagram, social media, YouTube, and then a lot of our bread and butter, acne, eczema, and our skin barrier. And I'd just like to say thank you so much to L'Oreal for putting on, and for La Roche-Posay for putting on such an incredible event. They always bring together such wonderful speakers, and I know that you worked really hard, Lisa and Siobhan. So thank you so much for hosting the event for us. Thank you.